honored and excited to introduce Kadija. We've had the pleasure of working together over the last couple of years to design and implement the Advanced Clinical Training Program here at the University of Washington. It's ACT. You can find information about it on our Barnard Center. If you Google University of Washington Barnard Center, you can link into and understand the ACT program. But Kadija has been our advisor on that program. It's advanced clinical training available to community members. It's a 15-month program designed for working professionals. And so it's been so fun, Kadija, working with you over the last 2.5 years to design that program. Kadija is a clinical social worker who's been a practitioner in the field of infant and early child mental health since 1985. She is the past director of the infant parent program at the University of California, San Francisco, where she pioneered an approach to infant and early childhood mental health consultation that now serves as a model for other organizations. She is locally and nationally and internationally recognized for this model. Currently, she's an independent consultant and adjunct professor at Georgetown University Center for Child and Human Development, and doing some great work there. She's sharing her expertise in infant mental health consultation and with the SAMHSA supported Center of Excellence in Consultation and the National Center for Behavioral Health and Safety. Kadija is active in several national early childhood mental health organizations, including the founding member of the Reflective Supervision Collaborative and RAIN, a Southwest Human Development sponsored group of national experts advancing practice and policy and research in early childhood mental health consultation. She writes and lectures nationally on infant and early childhood mental health consultation. In addition to numerous articles, she co-authored the book, Mental Health Consultation in Childcare. So she is committed, and we're so excited to have her share her enthusiasm and commitment to the field in her talk titled Addressing Racial Inequity and Inequality in Early Childhood Education Through Mental Health Consultation. So welcome, Kadija. I'm going to stop sharing. And for those of you, if you want to put questions in chat, I will track those. Kadija will stop about 10 minutes before. You can raise your hand and we will unmute you to address the question, or we can read it off in chat. So Kadija, are you able to?
I'm here, and it's right. Thank you so much, Monica. And it's really wonderful, both in the chat and in other places, to see several familiar faces and names, and also to see such a lovely turnout today. Turnout, that's an interesting word on Zoom. I don't know, we have to have a whole different vocabulary. One I haven't quite developed yet. I'm so pleased to be with all of you and to have had the last 2 years with you, Monica, to get to know you and the University of Washington and the Barnard Center more, to be able to, with NUCHA, to be able to develop the advanced clinical training. And today, and to have other work in Washington, I've had the great pleasure of providing technical assistance to several of the mental health consultation related entities at the state and locally. And now wanting to bring to you some of the thinking that I've been doing over the last decade around thinking about the ways in which our practice, a powerful practice of early childhood mental health consultation, can be a disruptor of inequities, particularly racial inequities. So I want to begin by giving you a sense of the terrain that we'll travel together in the next 45 minutes or so. I'm going to begin by describing research that may be familiar to some of you or all of you, that really reveals artifacts, examples of racism as it is embedded and expresses itself in one institution, early care and education. Our history leads us to know that in this country, I don't think there is an institution system that is immune from structural racism, and early childhood education is unfortunately no exception. Specifically, I'm going to cite studies on the racial and gender disproportionalities in expulsion and disciplinary practices amongst preschool aged children in early care and education settings. And then in the second half, kind of bifurcated in the middle, the second half or latter portion of the presentation will be devoted to describing a mental health intervention that appears to be an antidote to these inequities. The modality that is proving to diminish racial disparities is infant and early childhood mental health consultation. And the particular approach to mental health consultation that I'm going to talk very cursorily about, and which contains characteristics that are really shown to most consistently correlate or have a salutary effect on inequities, is one that I, along with colleagues at the University of California, San Francisco's infant parent program, and I see a few infant parent program colleagues on this call, we pioneered over now 3 decades ago. But I also, before beginning, if you'll still consider this the beginning, want to begin with a couple of caveats. I want to say that I have chosen to emphasize racism, specifically anti-Black racism, over other forms of inequity because of its pervasiveness and its structural strength in our country. But I, of course, recognize that other groups of people are still marginalized based on gender and ability and age and sexual orientation. But I'm going to focus on early childhood mental health consultations shown impact related to racism. And while I'm doing that, I think it provides the opportunity for all of us to think about, to introduce a framework that can also be applied to all of these other areas of marginalization. Another caveat is that as a white identified person, I do have some trepidation about speaking as if I'm an authority on racism, but conversely and equally as strongly held conviction is I feel I have a responsibility to use my unearned advantages for whatever positive possible impact they might have. So that kind of maybe self-imposed obligation is what leads me to be focusing on the topic that I've chosen today. I also want to say that when we speak of racism, or for that matter, any other form of harmful biases, we typically talk about historical antecedents and maybe inherited institutional structures that perpetuate racism impacting adults or even older children. We often talk about incarceration rates, or we talk about housing. And we're really less likely to maybe be knowledgeable, maybe not in this crowd, but we're usually less likely to be knowledgeable about structural racism's impact on very, very young children, or even to think about or focus on how early on racial difference is identified and bias based on race and gender is evidenced in young children. So I want to start then by talking about the beginnings. That's not surprising as an infant mental health person, that I always want to begin at the beginning with babies, by talking to you about when and how very young children, even infants, start to see and be seen in racialized ways. And I'm going to hope I can, given the sun shining on my screen, that I can advance my slides. Looks like I can. I don't know how many of you are familiar with the work of researchers at the University of Toronto and their collaborators, actually from other areas in the US, the UK, France, and China, that showed that 6 to 9 month old infants demonstrate racial bias in favor of members of their own race and against those of other races who don't look like them. In this group's first study that was published in Developmental Science in 2017, results showed that infants as young as 6 months began to associate faces that looked like theirs with happy music and other race faces with kind of sad dirges. In the second study, published in Child Development just a year later by that same group of researchers, they found that after about 6 months of age, infants were more likely to take cues, to take instruction from strangers whose physiognomy resembled theirs, whose facial features resembled theirs, even when the information that those strangers offered was inaccurate. They would follow the cues of strangers who looked like them. So what are we saying is that infants appeared to selectively grant similarly looking people, same race people, the benefit of the doubt under conditions of uncertainty, but not true of people who looked differently than them. And both of these studies, it's important to recognize, involved babies who had very little prior experience with other race individuals. So I think these findings also then point to the possibility that racial bias later in life may arise from our lack of early exposure and interaction with other race, other ethnic individuals. And I feel like this last study that I'm going to cite for now of slightly older children, for some of us very old children, you know, toddlers at 18 to 20 months, substantiates this hypothesis. Toddlers raised in bilingual households are more equitable in their kind of emotional resonance, who they will connect with, who they take cues from, who they learn from. And the greater amount of experience with racial and ethnic diversity, the less bias toddlers show. So I think most of us are aware of the astounding capacities that infants come into the world with. And this is just another one. The ability to distinguish difference and to make meaning about how they are responded to and how they respond in turn. And I think this attests to the extraordinary weight of early relational experiences on all of development, but specifically on shaping identity and a child's worldview. At the fundamental level of brain architecture, we know that the relational experiences, the moment-to-moment interactions that young children have with those who care for them, that shapes about 80% of the brain's actual circuitry. And so what I'd like us to think about then is, what does this mean in terms of the role of early care and education? Because for the majority of children in this country under 5, the primary people, in addition to a child's family, their parents, but the primary people responsible for the trajectory of that brain topography are childcare providers, early childhood educators. By 1 year of age, over half of the infants in our country spend some time, well, I said our country, and we have people from a range of countries. So I will say children in the US spend some portion of their day in the care of people in addition to their parents. And by 3 years of age, most children in this country are spending 35 hours a week in out-of-home care. So that childcare is not some small experience bracketed off from a child's life. Childcare is real life for children. Experience in childcare matters. Those experiences matter in terms of development, in terms of mental health, and in terms of racial identity formation. And the pernicious perpetuation of structural racism. And while early childhood educators are ideally positioned because they're with children for this much of the time, and they matter so mightily, those relational experiences they offered, they're perfectly positioned to offer experiences that promote positive mental health and racial identity. But I think it's essential to acknowledge the factors that strain the capacities of the people who, from my experience, are saints in the field of early childhood education, and strain the capacities and inadvertently often perpetuate the problems. What we have to recognize is that many in the field are having great stress, particularly in the last 2 years of COVID. But of course, the primary, in my estimation, pay is the primary problem in terms of the strains on early educators. The average hourly wage in this country of an early childhood educator is $10.70. And that translates to an annual salary of just over $20,000. And whether because of the stress caused by such low wages and the relentless demands of being an early childhood educator, those in the profession have among the highest rates of clinical diagnosed depression. A pre-COVID, so imagine what it must be like now, a pre-COVID study done by actually folks at the University of Washington, by in the public health sector at the U of W, showed that based on self-report, this is the report of the providers themselves, 40% of early care and education workers suffer from clinical depression. That depression rate among those workers is double that of all other low income, similarly incomed workers. So it's also something about the stress of caring for others, caring for children, and 4 times the rate of the general female population. But what I think many of us who work with early childhood educators recognize is, despite the pressure and increasingly the peril of the position, early childhood educators daily give greatly of themselves. And the field in general has made great strides over the last couple of decades to offer children high quality care. Equity in access is an explicit goal of early childhood education. And really early childhood education was founded on and grounded in the ideal that all young children deserve access to equal high quality early learning opportunities. And while that's always been the history, the mission, the goal and that there has been marked progress in the efforts to make early childhood education equitable in recent decades, there are still really grave disparities based on race, socioeconomic status, and gender with regard to children's access to, and maybe more importantly, well, maybe not more importantly, but equally as important, and their experiences in early childhood education settings. What we know is that when children attend high quality education, early education, there's a plethora of positive benefits, especially for children of low income families. Yet children of color who are low income are less likely to gain access to high quality early childhood education programs. For instance, African American children are least likely to be enrolled in early childhood programs that are considered high quality. And they're rated lower. African American children are rated lower on their school readiness by the age of 4. And one of the most glaring examples of disparities in early childhood education settings, I think, is in the expulsionary disciplinary practices. research that we have to date has demonstrated that children of color experience harsher discipline for the same behavior as their white peers. And again, starting as young as infancy and toddlerhood, children of color are the ones that are at the highest risk for being expelled from early care and education programs. In addition, really low resourced programs are more likely to be in low income communities where the staff also face many of the same stressors as the families they serve, including food and housing insecurity, unsafe communities, and a lack of health resources. Don't want this to be confused with overlooking the resilience in those individuals and communities, but also want to recognize how the interaction between the strains of the adults in those programs impact the experience of the children, particularly children of color. That evidence shows that unmet health and mental health needs in early childhood education staff, such as the depression and severe stress that I mentioned earlier, actually has a negative impact on the ways that providers interact with children. It's pretty obvious. If you're very, very stressed and don't feel resourced, it's hard to have the bandwidth, the emotional resources to interact in the ways that you would want to with the children in your charge. And this is often expressed then in wanting to exclude children because they are perceived as challenging or too much. Most of us are familiar with a study now done over a decade ago by our colleague at Yale, Walter Gilliam, who found that while African American children make up only 19% of preschool enrollment in the US, they comprise almost half of the preschoolers who are suspended or expelled. And in subsequent studies, he found that higher rates of expulsion were associated with those higher reports of teacher stress and depression, with larger classroom sizes, and with less access to mental health consultation. The primary factor that distinguished programs that expelled at high rates versus those that had little or no expulsion was the presence of a mental health provider. So when we think about suspension and expulsion, we have to think about what purpose also does it serve? Is it serving any intended purpose? And what are the impacts of a child being suspended or expelled? And I would say that while the short-term effects of expulsion, don't even correlate to the intended impact, right? Like what I would say, what people want when they suspend a child is the lessening of unwanted or unmanageable behavior. And it doesn't have that effect even. But the longer term impacts of early expulsion and suspension are doubly detrimental. Losing access to the needed referrals to other services and supports that might come if a child was in early care and education, particularly for children who've experienced trauma, who have developmental delays, is compounded over time if they are not in early childhood education settings. To say nothing of what it means to repeatedly receive messages at the age of 2 or 3 that you're unwanted or unstoppable or undeserving of care, or to feel that you're dangerous or threatening. Those experiences, those relational experiences in early care and education for young children accrue psychologically and are internalized into a child's very sense of who they are. Success in school and other aspects of life depends on a sense of efficacy and an at least benign, if not primarily positive view of who you are and what the world has to offer. We can, and I think should, be saddened, but not surprised that children excluded from early care and education don't typically do well academically later in life and face higher levels of incarceration. Some studies place that elevated risk of these outcomes as 10 times the likelihood for children who aren't expelled. As Walter Gilliam often says, young children of color have less front door access to really high quality early childhood education, and then they are pushed out the back door at disproportionate rates. So how do we explain what accounts for these disparities, these disparate disciplinary practices for children of color? Well, the reasons for suspension and expulsion are, of course, complex. I don't want to simplify it. And in most cases, they're probably multiply determined. Scholars and researchers have identified the 4 contributors that you see here: low program quality, inadequate knowledge on the part of providers of what is expectable of children at various ages, early childhood trauma as a cause for, again, not being able to understand that that's the cause for behavior or to support it. But the last factor here, racial bias, is the one that we're going to focus on. Why? Well, each explanation, each of these characteristics deserves attention and analysis. I'm going to focus exclusively on racial bias. Why did I choose this emphasis? As I said to you in the beginning, it is partly because it's personally important to me, and I feel committed to contributing to addressing structural racism in every aspect of my life that I can. But increasingly also, scholars and policymakers are hypothesizing that racism is the major contributor leading to disciplinary disparities. The US Department of Health and Human Services replicated Walter Gilliam's study and became properly more interested in these disparities and recognizing the racial impetus for them. We are seeing what leads to racial biases in perception. What are we seeing? We're seeing that teachers look more at African American children when they are told to expect problem behavior. This is another study of Walter Gilliam's that you may be familiar with, but for those who are not, I will tell you a bit about it. In this study, 140 preschool teachers were asked to watch a video of children in a childcare setting, and they were told to watch for where they thought challenging behaviors might be germinating. There were actually no challenging behaviors, even minor acts of aggression in the video. The children in the film were actually child actors, which isn't to say child actors can't act out, but in this instance, they did not. But those child actors were 4 children: 1 white girl, 1 African-American girl, 1 African-American boy, and 1 white boy. And what this study did was to track eye movement. An eye tracking advice was attached to all of the teachers. And what was found was that all of the teachers, regardless of their race or amount of experience in childcare, spent most of the time looking at the Black boy. What does it say? It says something about expectations, bias, preconceptions. I think it also says if you go looking for trouble, you're likely to find it where you look. We're likely to identify difficulty where we set our sights. 42% said the Black boy needed the most attention. In the second study that I'll cite, again, the sun is now moving and I really can't see my screen. Hope you can. Teachers were asked in this second study to read a description of a child's behavior and to rate the severity of the problem. The details in the description were all the same. They said things like, this child has difficulty napping, doesn't easily follow instruction, can't wait their turn. There were some ideas about that when the staff tried to intervene, the child screamed and ran away. But this same description was the only difference was the name of the child to whom this description was associated. And what was picked was a very stereotypical African-American boy and girl name and very stereotypical white boy and girl name. Actually, what was used was the most popular name of that year. The most popular African-American and the most popular white names were used. When a teacher who read the description was asked about whether she felt like she could help a child with that described behavior, teachers felt most hopeless in their effort to support African-American boys and in second place African-American girls. What's also important, I think, in the study was one other variable. In addition to the description of the child's behavior, some teachers were given information about a fictitious, this was all fictitious, family context. They talked about a home life that was turbulent, an absent father, violence in the home and in the community. And regardless of teacher race, white children's behavior were rated as less severe, suggesting what? An expectation bias. White children are expected to behave better, but also all teachers were more hopeless when they got the family background than when they didn't. I think this is especially discouraging, but very evocative for us to think about. It indicates that having information about a child's background, it gets associated with their race or ethnicity, but it doesn't kind of automatically encourage empathy. And there's another layer of complexity to these studies. When the teacher's race and the perceived race of the fictitious child matched, and they were given those family circumstances, both white and Black teachers rated the behavior, the severity of the behavior as lower for African-American children. They felt more hopeful if they matched race. And if there was a racial match, the teacher assigned less harsh discipline when they had the backstory. So what this suggests to me is empathy exists if we think we're like somebody. So if we think about this, particularly if we start to think about mental health consultation, it asks us to think about, I think, how do we encourage empathy across difference? And I will ask you to hold that, especially for those of you who practice mental health consultation. How does our intervention encourage empathy across difference? All right, so moving right along. I think we all know that efforts to address inequity should and can take many forms, from the individual to the programmatic to policy level. And many states and local communities around the country have been addressing the issue meaning of expulsions and suspensions and discipline in unequal disciplinary practices through laws and policies that severely limit or ban early childhood expulsion and suspension practices. I would suggest that policies are important but insufficient, and that we really have to look at other additional strategies. And the strategy we're going to look at for the rest of our time together is, regardless of where we target our intervention, we want to adhere to a notion that those effective interventions are, of course, best aimed at adults who care for children, who implement the programs, who make up the policies, rather than at the young children themselves. And early childhood mental health consultation is one of those interventions. So I want to, again, imagine most of you are familiar with consultation, at least cursorily, but I think it's always best to embed discussion in a definition. And I think of early childhood mental health consultation as an evidence-informed, multi-level, meaning that we work at an individual child level, a classroom level, a programmatic level, a systemic level, a multi-level mental health strategy that can be flexibly employed also along the care continuum to promote young children's social and emotional well-being, all the young children in an early childhood setting, but also to prevent mental health difficulties and to intervene with the adults in children's lives when mental health, developmental, or other concerns are already in evidence. And this it's an indirect intervention that pairs a mental health professional with another provider, in this case, an early childhood educator or educators, paired together to make a difference in through the development of a partnership among the essential adults in a child's life, the parents and the providers and the mental health consultation, to build the adult's capacity to reflect upon and understand the influences of their relationships, of their perceptions and interactions on young children's development, and to increase their confidence and competence to optimally support young children. So what do we know about the efficacy of this capacity building intervention? And I'm going to very briefly give you, you can review these later because you have the slides, or many of you may already know, some general sense of the impact, the positive impact of mental health consultation as it enhances qualities in providers like reflective capacity and sensitivity, and strengthens their sense of efficacy and lowers those stress levels that I said earlier correlate to harsher discipline and to excluding children. At the child and family level, we also have evidence of positive outcomes. Teachers view children's behavior as less challenging when they have mental health consultation. They also show gains in their perception, teachers' perception of children's pro-social behavior like self-control and communication and coping skills. There's a couple of studies that have shown that it reduced missed days of work for parents. Why? If you don't have to come pick up your child who has been excluded, you are more likely to be able to sustain work. So specific to expulsion, what do we know about mental health consultations, efficacy, excuse me. And as I said in the very beginning, specific to expulsion, Walter Gilliam's earliest studies showed us that children were least likely to be excluded from care when mental health practitioners were predictably present. You see the difference between on-call, which had a better effect than not having a mental health consultation or it being off-site, but on-site had the most salutary effect. Early childhood mental health consultation really has risen to national prominence in large measure because of its impact on reducing preschool expulsions. And it's that same research that revealed the inequitable distribution of the practice with regard to race and gender. I would suggest then that we have a responsibility to pay close attention to addressing in mental health consultation those racial disparities. But I don't think we should relegate our attention to expulsion. Expulsion is an extreme bellwether for racial, ethnic, immigrant bias. We know that prior to being barred from early care and education, many more children who are not have not been expelled, but experience daily microaggressions, distortions about who they are, fueled by implicit bias, by racism. And while that's detrimental to anyone, the experience is doubly dangerous for very young children who are internalizing for the first time those awful attributions about messages about who they are. It forms their core sense of themselves. As I said, I think expulsion is a very big bellwether that we should not relegate ourselves to thinking about. And my dear colleague Eva Schreiber in Arizona has shown that mental health consultation's salutary effects are not just in relation to expulsion. She did the research on Arizona's statewide early childhood mental health consultation program called SMART Support. And what she found is that mental health consultation is impacting these less extreme, but no less dangerous distortions. Initially, providers who had asked for mental health consultation around a specific child initially cast African American children as most problematic in terms of the show of least initiative, most aggression. When asked, who do you, when you're driving to work, hope will be ill or not there that day? These were the children that rated highest or conversely lowest in these areas. Teachers felt least attached. They felt these children were at the highest risk for expulsion. However, after just 6 months, which seems relatively short to me, of mental health consultation, African American children, and specifically African American boys, were rated by their teachers. So it's important to think about, this is not talking about necessarily that the children's behavior changed. What changed is the perception of the adult. That the adult's perception changed such that those same children 6 months later had in the teacher's mind made the greatest positive shifts in relation to all other children who were also the focus of consultation and cause for concern. African American boys showed the greatest positive growth on all measures, and those were sustained over a 12-month period, checked back in on after 12 months of consultation. And while we should celebrate these findings, I think we still have a tremendous amount of work to do. And one important aspect of our charge is, I think, identifying what is the mechanism through which mental health consultation addresses bias? How were we able, through mental health consultation, to make these changes? What are the pathways of our transformative process, particularly related to the impact on racial bias? And there's beginning to be both theoretical, but now for those who give more credence to empirical evidence, we're starting to have that as well. And that is that it really has to do with our impact of effectiveness as mental health consultants, has to do with the quality of the relationship we create with our consultees. This relationship reflects the extent to which the teacher and the mental health consultant perceive that they are partners. These are the words used by consultees, teachers, who in turn saw the most positive impacts on child outcomes. They describe their relationship with the mental health consultant as a team player, as having a partner in the work. That there were ways in which there was no hierarchy to the relationship, that they were equal partners. This stronger consultative relationship is thought to be facilitated by a consistency of availability, as we saw in Walter's research, but also by coming to mutually agreed upon goals with the consultee. The consultees also said the consultant's ability to take multiple perspectives, the child's perspective, but also the adult, their perspective, that the ability to communicate clearly, to show respect for the unique culture of each child, but each child care community as well, and the willingness to lean in to potentially difficult topics are all being correlated to positive relationships between consultant and the staff they serve, and in turn to positive outcomes, particularly for children of color. And relationship, this positive relationship, has a special role in reducing implicit bias. What Eva Shiver also found in her work, that when the focused child was a boy of color, what mattered most in terms of the type of the positive relationship, what contributed to that positive relationship when the focused child was a child of color, was one, when the consultant rated themselves as having expertise, as having done self-study and critical self-reflection in an ongoing way. Those consultants that considered themselves knowledgeable about and invested in equity, diversity, anti-racism practices, and or when the teacher and the mental health consultant were racially or ethnically matched, that's where the greatest positive impact in terms of perceptions of positive perceptions increasing for children of color was evidenced. And our colleagues at Georgetown, Annie Davis, Deb Perry, and Laura Rabinowitz have outlined this possible pathway of how mental health consultation might work to reduce racism and implicit bias. And I hypothesize that the changes are due, at least in part, to really focusing our relational stance to the places where we witness the kind of psychic seepage of racism and other harmful biases, to be explicit about addressing bias, especially when we're talking about implicit bias. It's by definition, what does implicit mean? It's unconscious. So that part of what mental health consultation does is to try to bring the unconscious beliefs to consciousness. We ask ourselves first, and then we ask consultees to acknowledge contributors to their attributions about a child. What is making this provider feel as if this 2-year-old who inadvertently takes a swipe at their face during a dysregulated moment, what makes them label this child as threatening or a sure sign that he will be a predator in the future? We ask, we wonder about, we're curious about, and try to bring to consciousness those attributions. We try to promote empathy and it promotes self-reflection and increase empathy. And as I was thinking about the factors that hopefully contribute to mental health consultation being a disruptor of racial inequities, I was reminded of and kind of struck in a positive way by the similarities between some of these factors that I've identified as possible mechanisms of change. I was struck by the similarity between those and the framework posited by Bryan Stevenson. Many of you may be familiar with Mr. Stevenson. He's a public interest attorney. He's the author of the book Just Mercy, and the founder of the Equal Justice Initiative, an organization in Alabama that strives to eliminate discrimination against African Americans from the U.S. justice system. And what Bryan Stevenson says is, he says our efforts toward injustice to be effective, they rely on 4 pillars: getting proximate to the problem of racism, getting close, something often we avoid psychologically or physically. 2, changing the narrative about race from blaming the victim to changing the system. 3, be willing to tolerate discomfort. And lastly, maintaining hope in the face of often brutal facts and acts. And so hope is what I want to leave you with. Let's all hold hope and put into action our beliefs that change can happen. And additionally, I hope you'll just remember these following messages about the ways in which mental health consultation can be a disruptor of racism at a crucial point in children's lives, the beginnings. Thank you.